Commissioner Charles-Smith.
I did have some prepared remarks, but was fortunately able to attend many of the workshops today and to sit in those. And so what I thought I would do is change it up a little bit and talk about some of the things that I've heard being discussed, and there's some things I want to make sure that I clarify or clear up, and also some things that I want to talk to you about what we're going to be doing at the system, HHS and HHSC in particular, moving forward. First and foremost, I want to talk about the 1115 waiver. And we spent a lot of time working with CMS, had a lot of assistance from many individuals and associations and so forth in Texas. I was very appreciative to have Governor Abbott's attention in this, and it was one of the highest priorities that he had. He and I made a couple of trips to DC ourselves to talk to administration personnel about the 1115. But some of the things I wanted to just kind of talk about are, the pool sizes. And when we are looking at the 1115 waiver and what this does for us, it's often categorized as that there are three components to the 1115 waiver. One is it gives us the ability to have managed care. The second is it gives us a vehicle for uncompensated care, and we have a pool that's associated for that. And of course, as you all know, we have DSRIP, the Delivery System Reform Incentive Program, that is also part of that. And that encompasses roughly about $25 billion over the course of this waiver. But it doesn't end there. We also have the Uniform Hospital Rate Increase Program, Europe, UHRIP. We like to name things. And what this does is it allows the hospitals to be able to chip away at some of the uncompensated care as a result of the Medicaid shortfall. And so this is extremely important in the form of directed payment. And so we were able to submit a concept paper and worked through that with CMS, got it approved, and we have worked with the hospitals and the managed care organizations, and so we'll be launching this program. And if you notice in the 1115, and for those of you, it's on our HHSC website, you can just Google HHSC 1115 waiver and access it and see the spreadsheet. It starts out with $800 million in DY7 for Europe. And by the end of the waiver, DY11, that amount is $1.5 billion. And so it grows. We were able to get growth over the course of the waiver. We also have the Network Access Improvement Program and the NAPE. So that program stays at $426 million over the 5 years of the waiver. Followed up with our Quality Improvement Payment Program for our nursing facilities that starts out at $400 million, and by the end, DY11 concludes at $600 million. And so when I say concludes at $600 million, that's because in DY7, $400 million, $450, $500, $550, $600. So it's more than $2.25 billion that will allow us to focus on quality initiatives for those individuals who are in nursing homes and nursing facilities. And I know that this morning you heard Senator Swertner and some others, Eddie Paredes from one of our nursing facility providers, talked about healthcare and the quality that's associated with the nursing facilities. So when you start looking at all of this in total, those programs themselves total up about $10 billion over the course of the waiver, coupled with the other almost $26 billion. That's almost $36 billion for the waiver. And that's in addition to the hundreds of millions of dollars that are part of the ongoing effort toward managed care. And even with that, we still have some unspent cap room in this waiver. And Senator Swartner was talking about this morning that we'll have an opportunity, the legislature will have an opportunity to talk about and look at other types of funding mechanisms along the way. And so it's a tremendous opportunity from Texas. And we really are in a very good position. One more thing about the uncompensated care and the district pools. In DY7 and DY8, we have $3.1 billion in our uncompensated care. And if you look at DY9, 10, and 11, you'll see $2.3 billion there. And some people have taken that into account that we have, and we're going to be cut with our uncompensated care. That's not exactly the case. We were able to negotiate a placeholder in those years while CMS works with us and we work with the hospitals to get our protocol set so that there's a rebaselining of the uncompensated care pool, because CMS is requiring the Medicaid shortfall and to come out of that calculation, as well as the hospital bad debt. And so they're looking at strictly uncompensated care as it relates to the uninsured population for this waiver. So as we've gone through and made those adjustments, we fully expect that those 2.3, based upon some projections and conversations, that amount can increase. We don't expect that it's going to go lower than that, but if it does, then we don't lose that money. Texas doesn't lose that money. It gives us the opportunity to be creative and design other programs to help people in which to still draw down those federal funds, as long as we're able to come up with a non-federal share on the state's behalf. The other part of the DSRIP, DY7 and 8, we start out at $3.1 billion, then it drops down to $2.9, then $2.4 billion in DY10. And as was said earlier, in that last year, DSRIP is zero. We don't lose the funds in that budget of accountability. We have the opportunity to do something else with those as we're creating new programs, but we'll have to go through the CMS concept paper process, or at least add those funds into other programs that have already been approved by CMS. So it's really a tremendous opportunity for us. And so I wanted to make sure that everybody got that. And as I talk about DSRIP here in a little bit, and about some of those things that will be coming along. If there's any theme that I've tried to communicate to our people within the system, as well as those as I've traveled around the state, is transformation. Transformation is what we did as a result of Senate Bill 200. And transformation is one of those things that with my state government experience that I've done throughout my career. And that is focus on continuous improvement. What can we do to eliminate silos? What can we do to enhance our processes? How can we better integrate technology so that we can really make sound decisions? And what we do about all of that, first and foremost, is we create, if there isn't one, or we at least make sure we understand the legislative intent and behind the vision that it takes to drive our system. And I will say that while there is a lot of people that may disagree, the legislature has invested mightily in our healthcare system. And there's a lot of funds that flow through the system. Now, whether or not we believe that they're flowing appropriately and effectively and efficiently is a different story. And I think that's where we'll be continuing to look to see what we can do as a system to help drive this process forward as we begin to work and have conversations and collaborate. So for me, the theme is transformation, continuous improvement, and collaboration. Because we're not going to sit and totally dictate to you what to do. We're going to sit down with you, make sure you understand what the concerns, the problems are, the limitations are, and then let's together develop and build the best healthcare system we can from the Medicaid perspective, because that's the area that I have been given charge over. So we want to be focused on positive health outcomes. And what that means is we want to restore people to their being the healthiest person that they can possibly be when that is the case in the circumstance. One of those things that we look at is what I call kind of the big three: hypertension, high cholesterol, diabetes. And so we want to see that we see the economic costs that are associated with them and how they can change a person's trajectory in life and have all of these downstream costs associated with it. And, where not only medications, but if the person is still eating unhealthily and not working out and those type of things, is that it then begins to lead to other aspects, whether that is, eyesight loss, bone and joint issues, kidney issues that then lead to surgeries and all these other things. And so there's a way that we can begin to focus on positive health outcomes for people to actually help transform them into a place where while we're treating them holistically and we're treating them as an individual and we're having patient-centered treatment, it also, by the way, begins to save us money and save us income. And so that's the part that we need to really focus on. And what can we do through improved health and individual patient-centered care that will help through prevention and help people recover so that we can then have cost avoidance over time. And we'll have to figure out how best to communicate and build and show the analytics and the metrics behind this so that we can then, working with the legislature, they'll see exactly where we're going and why, and that we'll be able to get buy-in holistically. I also want to say that managed care, the managed care model that we have, is a more cost-effective delivery model that can provide a high level of quality if properly incentivized and overseen. Managed care, the delivery model that we have, is a more cost-effective model, but it has to be properly incentivized, and we heard people talking about that throughout the day. And it has to be properly overseen. And that is where my agency comes in, ensuring that we are exercising proper contract management and oversight. Because what I'm going to try to do is to focus our agency not on processes, but to focus on outcomes. And so we want to make sure that when we're looking at people and care coordination, we want to eliminate silos. We want to have better metrics, which will give us the opportunity to really see where more emphasis needs to be placed, where we can ask those critical questions of the managed care organizations. We want to make sure that people who are supposed to be getting, whether it's durable medical equipment or supplies or those type of things, that it's actually happening. Because if that care coordinator has said this is what's necessary, then for that person to either have greater independence, better health, and better health outcomes, then we want to make sure that that's happening. But we want to make sure that we're also supporting the whole process. And which brings me to DSRIP, because I know that there's been a lot of conversation about DSRIP dollars going away and what we're going to do. We're going to have conversations and bring the provider groups together, because DSRIP is one of those areas where when you start looking at the care that's necessary for people in El Paso or Texarkana or Brownsville and Amarillo or Perryton and the Panhandle, it's different. And one of the things that has really worked well about DSRIP, in my opinion, is that we've had local providers understanding their local communities and what they need in order to provide better health care. And what I want to see is those providers having dialogue with the managed care organizations as we're looking at incorporating managed care value-based purchasing into our contracts, 25%, and you heard that it's going to continue to move up to 50%. Kay Garamani was talking about in her workshop. And so as we continue this, what better place than the metrics and the analytics that we've received over the last 3, 4, 5 years regarding these district projects. As I've traveled around the state, there has been no shortage of people telling me about how wonderful their projects are and how it's bringing down costs and how people are getting better health care. Then they should be able to have that conversation with those managed care organizations that are in their RHP or their SDA and explain to them why this is something that they would want to incorporate into their plan and those type of things. Because if it's about better outcomes for people, saving dollars in the long run, then I will imagine that you'll have some ears that are willing to listen to you. The other side of this is that there may be some of those programs that might not find out that they're best suitable for this, for the model. And so there will be an opportunity where we're starting to look at the future and our continuation of the waiver. What other programs, what other needs that are there that we can incorporate? An example of that is in managed care, we're making sure that we're getting better utilization of mental health and behavioral health in our different programs and our different SDAs around the service delivery areas. Sorry, I'm jumping into government speak. And so as we are continuing that, there still may be some opportunities where we can develop mental health initiatives that will operate outside of the core managed care area that we can get to build and move forward with if we're able to get buy-in from stakeholders on what needs to happen. We're able to get the legislature to want to either invest in this or to approve the direction that we're moving in. And so we can begin to look at the services that may not be there. Many of the fall in the crack type services, whether that's with veterans, women's health issue, maternal mortality, all of these different things. We have the cap room and availability to begin to redesign and think about what we can do going forward. Contract management is another one of these areas that has to be considered. It's our responsibility as the agency that oversees Medicaid and the managed care model to make sure that we're providing proper oversight of our contracts. We're not perfect. Haven't been perfect, probably aren't going to be perfect going forward in the future. But what we're going to do is we're going to continually get better. We'll get better internally from our own processes of our staff, looking at us and trying to figure out where the weaknesses and where the linkages are, where there are opportunities to collaborate and improve. We'll be responding to audits from our own internal people, the Inspector General's office, the State Auditor's office, anybody else that wants to come in and audit and say, hey, here's an issue that you need to resolve. We're going to look at it, take it, incorporate it, and if it requires us and needs us to make a change, we're going to make a change because we're going to be content and focused on doing the right thing for the right reason. We're going to make sure that as a state agency, we're responsive to the taxpayer funds that we have. And so we're going to make sure that we're going to be focused on data. We have to have data, not just data for the sake of data, but the data has to be actionable and it needs to be relevant. We do a great job of monitoring encounters and claims and all of those type of things, which is to me a vestige from the fee-for-service world, but we haven't really incorporated and changed and transformed ourselves into the delivery of managed care. And that is not something that has started with me. I've had conversations with some other people within the system, and they will echo and say the same thing. So my response is, okay, so what are we going to do about it? So how are we going to begin to address it? You can't just say, here's an issue, here's a problem, and then not do anything about it. So it's, What's your plan? Put out some actionable items. Let's begin to see some milestones, and let's figure out what success looks like. And so that's the way we're going to handle it. And we're going to let this data, this information that we get, really focus us on driving decisions. Not just be focused on, driving down cost, because it's easy to drive down cost, as we've heard people talk about, whether or not you take things away and those type of things. That drives down cost in the short term, but it drives up cost in the long run. It can. And so that's not really the focus that we want to make. But I believe that we can make decisions today that will drive down cost, but that will continue to drive down costs in the long run. And so we want to make sure that we have adequate networks. We want to make sure that we have the appropriate levels of care. And that's going to be a conversation and a discussion that the people down at the members of the legislature down at the Capitol are going to have to weigh in on regarding what is truly their vision for Health and Human Services Commission and its delivery of health care and managed care in the future. The other thing that we're going to stay focused on, the third, is quality. I can't underscore enough what it means to make sure that we have a system that is focused on quality outcomes for people. We want to transform our payment system to focus on outcomes. We want to focus on our delivery system and how better to ensure that people's needs, basic needs, are being met, and it gives them the best opportunity to live, whether it's pain-free or be able to return to work if that's the case, or even with that person who has a developmental disability. What can we do to ensure that they're having the best quality of care so that their life is the best that it can possibly be? And we want to make sure that we're focused on positive outcomes for people, and we can begin to look at and drive toward that system. We want to identify the proper incentives that lead toward holistic and lasting change. We don't want to just do something today and then move off and not realize that it hasn't been institutionalized. We really want to have an understanding of big picture and what does that look like. To me, if we had the ability to look at each individual person and see whatever their health or medical needs were, mental health needs, and then say, based upon this, where can this person be, and how can we then get them there? And then what we need to do is be able to figure out how to incentivize the system that, as you heard Dr. I believe it's Bozic today talk about, that, and as well as Chairman Zerwas, a system that is based upon a fee-for-service model to actually begin to incentivize it to change to where we're focused on health outcomes. Because if that person's pain is being properly managed, they're not coming back to the doctor's office, then what does that look like, and how far should you incentivize and reward a provider for being able to do that? Because that person isn't coming back to an emergency room, or they're not going to some other place that might even be inappropriate for the level of care. And so we have to figure out what that looks like. And so we're going to work with managed care organizations, providers, and recipients of service to help us design and figure out what the new system and have these conversations of what that looks like and how we can best incentivize it as we look and move forward. And those conversations will be happening throughout the course of the year and for possibly a few years to go. As Chairman Swarton was saying, that they were going to be looking at how best to do this over the next couple of legislative sessions. And we want to make sure at HHSC that we're bringing people together and having these conversations so that we can also provide meaningful information to the decision makers so that the policies that they make are geared toward helping, which is, I believe, all of them want to do. And we heard, it depends on what workshop they're in. I keep saying we heard. Representative Howard talk about that, all of the members kind of want the same thing, but the difference is on priorities and what to handle first and how to get there. And so what we are able to do, hopefully, is to have this dialogue so that we can present an opportunity or a roadmap and then allow the decision makers and the policy makers to decide where to go. The fourth item is collaboration. Opportunities to share data and people for holistic holistic work. And so this collaboration for me comes through dialogue and discussions. We're going to, again, look to see where there's the ability to capture cost and avoidance and savings and averted cost, and how we can truly build a model where it stands up independent testing, independent scrutiny, independent verification and validation, so that they're not just saying we're just creating something, but that they can actually see and test, and we get the approval. And so this is going to take, again, a joint effort from the legislature, the managed care organization, the provider groups, and when I say provider groups, that's hospitals, physicians, therapists, ambulance providers, everybody that is part of the healthcare system. And then the final thing I want to talk about is this transition. As best as I would like to snap my fingers and have all of this happen, first thing Monday at 8 o'clock, I realize that that's not possible. I was talking to Chairman Sheffield a little bit this morning, and he was asking, how things are going, are you hanging in there, those type of, and I said, well, I used to think that this was like changing, turning an aircraft carrier. And I said, but no, it's like a flotilla. It's a little different. You slow it down, get it to turn, and then somehow get it to speed up. But the point is that that commander of that battle group at some point has to decide where to go and when to make the turn. Even though the inertia continues to push everybody forward, at some point they get to a point where they can begin to make the turn. And that's what I envision my role in this is, getting everybody together, talking about and deciding and a clear vision of what success looks like. And then let's then begin to start working together to achieve it. Because if we're able to do that, and when we're able to do that, the health outcomes for the 4.5 million lives that we have in Texas, in Medicaid and CHIP, will be tremendously improved. Maybe we can have an opportunity to change the trajectory of healthcare cost, besides just taking because of the work together to design a new way of incentivizing, paying for, and working toward this common goal of better health outcomes for people. That maybe there are some people I've heard, I don't see her here this morning, I didn't get a chance to get her name, where there are people who have needs that we're not able to meet. And we have the opportunity to be able to do it. Because as the members talked about, there's a finite amount of money when it comes time to them trying to figure out exactly what the state needs. And people invest in places where they see the most return on their investment. And where else can that be better than in the lives of our children, the elderly, and in those who most need the help? And so I know that we can get together and drive the future of healthcare in Texas. It's not going to be me dictating to you, but it is going to be me pushing you to come to the table and help us design and to work together so that we can figure out the best way to get to where we all want to be, and that's better health outcomes and to ensure that the healthcare system we have is the best system that we can develop and that we can fund and that is sustainable for years to come. So, thank you.
Commissioner, I appreciate your comments, and as you said, and as we were discussing before this, $25 billion in a waiver is a lot of money. $36 billion is even more, right? I don't have to be a math major to figure that one out. Tell me just personally for a minute, just you and me and a bottle of water here. What was it like personally going through that negotiation process with CMS? Because it's generally a rigorous and onerous time in a normal time. The federal government is not, it's a little unique right now. How was that sort of process going back with the governor and kind of banging on the doors of CMS and having them open up to you?
I will say that as we started out, we had the governor and I went up and we had a conversation with Secretary Price, and we went back and had a conversation with Administrator Verma, and then subsequently I had numerous conversations with them and others, and the governor continued to have conversations with people also. But from my perspective is there was a definite willingness where they said we want to work with Texas and on the waiver and get this done. But there was that, but then there was a tremendous amount of frustration because I wanted to get this complete by May. And we started out actually, I submitted a letter in January last year asking for a 21-month extension to give us an opportunity to see what Congress was going to do regarding health care, Medicaid, and so forth, and to give us an opportunity to really begin to look at what we needed to do in response to what Congress did. But the administration wanted to continue to move forward, and there was a lot of frustration and aggravation and weeping, moaning, gnashing of teeth. That's probably from their perspective dealing with me. But I will say that we eventually got there. We have a tremendous amount of staff at the system, HHSC, that continually worked with the CMS professionals and hammered things out. We didn't get everything we wanted. They didn't get everything they wanted out of this. And I think ultimately where we ended up was the best place that we could be for Texas. And I think overall for the waiver, it still turned out to be a very good waiver for the state, for us to be able to fund health care. Because the first part was, with this waiver, let's keep everything in motion. And once we get that set out, then we want to make sure we start having these conversations about the future.
One of the observations since you have taken the position is that there's been a lot of turnover at the commission. There's been some, as you say, gnashing of teeth amongst folks who are on the outside looking in. There's an old line in state government, which if you haven't heard, you can relate to, which is people don't remember how quickly you make your hires. They remember whether you made the right hires. How would you say things are in terms of staffing at the commission? Do you feel like you got your team in place and you're ready to go, or you feel like you still it's an ongoing, ever-evolving process?
Well, I would say that the team we have now is a very, very strong team. I am excited about everybody that we have in the positions. We still have a couple of vacancies that we're looking to fill. But the one thing that I have told them, because I keep the same amount of pressure on myself, is you're only as good as your last game. And so everybody, every day, needs to come to work and bring their A game. Regardless of what's going on in their personal life or their issues, when you come to work, you've got to be able to put all of that aside and focus on the items that are there. We don't want to just exist. We want to thrive. We don't want to just continue the status quo. We want to question why we're doing things. And if there's a better way, then we want to move on it. So one of the things that for me within the system is trying to get people to understand the sense of urgency. And I know that a lot of times people probably think everything is urgent. And because my point is, if you identify a problem and 3 months later, 6 months later, you haven't done anything to address it, but you know where the problem is, then that hasn't helped anyone.
Yeah.
So identify the problem and then come up with a way to resolve it and then start the process. You may have to prioritize some other things. Priorities are always going to change. And that's what we're gonna do. And I think the team that we have is going to be focused on that. We're going to be stressing operational excellence and making sure that we're at the top of our game so that as the healthcare system and our interaction with all of our vendors and contractors, we'll make sure that we're able to hold them accountable and create a working environment that is not adversarial. Mm-hmm. I don't want anybody to think that, because it's a partnership, but it's a partnership with us having responsibility. And we can't advocate that upon anybody else, whether they are imaging documents for us or they are working on prescriptions.
Well, I think, to reflect what I hear from stakeholders, and again, I don't talk to everybody, and not everyone tells me everything they think, but generally speaking, I hear pretty good and solid praise for kind of your steady hand of leadership. A year ago, there were some more question marks, right. But now I think people are feeling pretty confident about the direction of things. I also think that it is just empirical, whether it's 25 billion or 36 billion, that's a lot. Oregon was we heard from Governor Kitzhaber this morning, and that is a transformational model that they have there. That is a state that is 1/7 of the size of Texas. Right. The equivalent would be 14 billion. In other words, right. If you multiply theirs by 7. So that is making it apples to apples. It's a big money, a big chunk. Tell me how you view, setting aside the waiver for a second, how do you view the pending round of procurements in various lines of business and Medicaid as a tool to further push the system forward?
Well, that's a good opportunity for us to implement some of the changes that we believe are necessary to transform the system. It's an opportunity for us to really begin to drive toward those aspects of success. But it doesn't just start with the release of the RFP. It shouldn't start there. It should start with us having conversations with in the managed care world, with our managed care organizations, our plans, and to find out what are some of their needs and what are some of the things that need to be addressed maybe through a contract. We need to have conversations with stakeholders, stakeholders being hospitals and providers and individuals who are in the system to understand what we need to do to continue to move forward. And then we also have to take the state policymaker vision and make sure that that's incorporated. And the RFP should be the culmination of all of those things that are really forward-leaning, that we believe are geared toward success. And again, many of our RFPs, and we haven't gotten there yet because we're still moving through this process internally, are what I'll call widgets. Mm-hmm. They count processes and pay for those and don't do this and X number of these you have to do. And they're really not focused on outcomes. But one of the things that we have to do as a system is develop a clear vision of what success looks like. And then we want people to go out and achieve that success. And in doing so, we will then hold them accountable if they're not, and whether that's at risk and those type of things. But the RFP is that process that will help drive that, and then we can make some changes to the contracts through amendments on an annual basis or more frequently as needed if there are some things that we later determine that should have been included that weren't included, or we learned something new, then there's an opportunity for us to amend the contracts and move forward.
Yeah, good. Well, I think I just am so appreciative that you have been here all day. And I think it's a testament to, I think that's worth a round of applause. I think it's a testament to your willingness to engage directly with stakeholders and learn and listen. So I think it's kudos to you and thank you for your time. If you could leave us with the wisdom of all of your earned experience and give us your counsel and advice for how to get through the next 364 days until we meet on this stage again next year, what counsel and advice would you give to folks in the room and watching this online?
How do you eat an elephant?
One bite at a time.
One bite at a time.
Yeah.
But in order to eat the elephant, you have to what? Start biting. That's what we're going to do.
Yeah.
We're going to identify what needs to be done, and then we're going to develop a plan of action, and we're going to operationalize it. And so as we continue to move forward, that's what we're going to do, and we're going to do it collaboratively and collectively by reaching out. And so thank you all for letting me ask you questions throughout the day and sitting in because this is it's who I am as an individual. It's who we're going to be as a system. And so I think as long as we're able to work together, we can do tremendous things in Texas. So thank you.
Commissioner Charles Smith, let's give him a round of applause.